This is going to be a one-slide video, and it talks about value-based care partnerships. One of the things it will do is help you understand the progression from fee-for-service into very early fee-for-value and all the way into full-risk programs, full fee-for-value. And you'll see, I'll talk with you a little bit about the finance associated with these as well, including the value of a patient given their level of maturity in this process financially. So fee-for-service, that's just traditional fee-for-service reimbursement. It's an E&M, 405, one of the simpler E&Ms. Or let's say it's 2 or 3. Let's say you bill a total of $400 that year on that patient. That is the care that you've provided. You've written a few scripts for that patient, patted them on the back, and they've left. And that is fee-for-service. That's what most docs have. Medicare has been pushing things called an annual wellness visit. And as soon as you start doing annual wellness visits for patients, you are tiptoeing into fee-for-value, because an annual wellness visit is not an E&M, evaluation and management. It's a CPT code. It's a procedural code. The procedure, it doesn't involve labs. It's a procedure where you're helping the patient develop an assessment of all of their illnesses and develop a plan for prevention. Medicare has found that when that happens, the patient is healthier. That only makes sense. If you have a plan to stay healthy, you're more likely to do it. Now, talking about tiptoeing into that early fee-for-value, one of the things that we did in the Alabama program, for example, was get physicians who didn't know how to do AWVs, get them started in the AWV program. You'll also find some bonuses in there as well, and that's when you really start getting deeper into fee-for-value or population health. The bonuses, typical bonus would be $100 for an AWV for a patient, but if you do AWVs for 80% of your patients with that payer, like 80% of your patients with Humana, instead of getting $100 per patient, you now get $200. So what they're doing is rewarding you not based on more volume of care like the hospital does their primary care doctors. They're rewarding you based on your population basis of medicine, your denominator medicine, your ability to make sure that you're doing the proper preventive care for every patient in your practice. So that's an incentive program. Before we get completely out of fee-for-service, I'm going to make another couple of comments about fee-for-service. You see, Medicare has continued to decrease their compensation for fee-for-service activities, their E&M codes. But one thing you'll see is, yes, they've greatly increased the compensation for fee-for-value or preventive care, population-based care. They're also actually turning straight Medicare, quote, fee-for-service, into more of a fee-for-value or population-based program. Now, what do I mean by that? Take a look at CCM, chronic care management. We'll do separate videos on that. But CCM, if you haven't heard of it, RPM is similar, transition of care, TCM. So RPM looks at things like blood pressure cuffs. You have your patients take those home, and if you get them to send their blood pressure into you 16 days a month, and you interact with them a certain 20 minutes that month with them or their chart, then you get paid for that. That's over in fee-for-service, but that's clearly a population-based program. So as you can see, even though Medicare has set up a whole new set fee-for-value or value-based care reimbursements, they're also, meanwhile, turning straight Medicare into fee-for-value, whether you know it or not, by decreasing the fee-for-service E&M codes and increasing programs like CCM, TCM, RPM, which are more population-based medicine. Now let's go further in the fee-for-value programs. Again, the black arrow here is fee-for-service. The orange arrow is getting into doing those AWVs and starting to do 80% or more, that population-based performance of AWVs. There's another thing that you can get into, and you can debate whether it's incentive programs, shared savings, early or mid fee-for-value. But it's very valuable, and it's a very good next step for doctors, and that is capitation, or PMPM. PMPM stands for per patient per month. So a typical capitation program might be Cigna saying, hey doc, we will provide you X number of dollars per patient per month that you carry for Cigna in your physician panel. Now, what do those range? I've seen them as low as $15, especially in some Medicare or Medicaid programs, well over $50 in other types of programs. It just depends on what you negotiate with the payer, but most of all, what the rest of your contract is, what additional fee-for-service billing you might have in there, and things like that. So we get over into shared savings, the blue one, and that is as you start getting into risk assessment of patients and risk adjustment and risk management, which are very technical. We have a whole course on it, by the way. If you'd like to get the course, just call us, 859-721-1414. That's 859-721-1414. Once you start getting into risk management for your patients, then Medicare and the payers will start setting up shared savings programs. And again, let me give you a typical example. Let's say a patient 65 years old, and I know one very similar to this example, where he's been diagnosed with diabetes with hyperglycemia and atrial fib. You'd never know it. Most people think the guy's 50 years old. And if you had 100 of these, you're not going to end up with them in the hospital very much at all. But with diabetes with hyperglycemia, that's got a RAF adjustment of 1.3, atrial fib, also a very high risk issue, which needs specific care by the patient, another 1.3. You multiply those out, add things like hyperlipidemia, hypercholesterolemia, some of the other things that would go along with that. You start getting a patient RAF score, risk adjustment factor, RAF score, closer to 30,000 or 2. Now 2.0, the typical patient right now, this was just 5 years ago, the typical patient cost Medicare $15,000 a year. So $15,000 as a 1.0, then you multiply that risk times 2.0 and you get a $30,000 Medicare budget for that patient for that year. Let's go back to our healthy guy that has documented full-blown diabetes and documented atrial fib and a few other documented things and a risk adjustment factor of close to 2. Well, let's say he's taken GLP-1s and he's taken Xarelto for his atrial fib, stroke prevention. So overall, he's got a couple of expensive drugs, up to maybe, let's say, $6,000 a year. That's high, but we'll say that. But they've budgeted $30,000 per year. So at the end of the following year, you have 100 patients like this. That one patient was budgeted for $30,000. Now they're down, only $6,000 were spent. So Medicare's got a $24,000 surplus. In many shared savings arrangements, Medicare will take half of that $24,000. They'll share that remaining, so half would be $12,000. They share that remaining $12,000 back with the rest of the healthcare system. That would typically be in a large, well-developed, full-risk model. A payer like Humana or Cigna take 50% of that $12,000, and then the primary care system take another 50%. Now, you're not going to see that level of care for individual doctors. This is one of the reasons, as you start getting into this level of care, that level of shared savings usually involves risk models as well. You can get shared savings. We went through how shared savings occur, but you're not going to get full shared savings until you get to full risk as well. So again, an individual doctor is not going to get into these kind of activities. Maybe some bonus programs, not likely to get too deep into shared savings, and clearly cannot and should not get into risk models, because that cuts the other way too. You may have a patient who, and this is what's typical, a patient that hasn't been well managed. They've been in fee-for-service only. They come in, like our very first patient in the Alabama project. They come in and they say, I don't have diabetes. I saw 6 doctors last year. Their fasting blood sugar was 205. I didn't say glucose tolerance. I said fasting blood sugar was 205. So they clearly had full-blown diabetes and ended up in the hospital that year twice. And guess what? That patient had a risk adjustment factor coming in of 1%. 1.0 because no doctor was watching his risks. The docs just had him in fee-for-service land. They were just bringing him in, writing a script, patting him on the back, and sending him back out. And he said to us, "I know you keep bugging me about potential diabetes. I don't have it. I took your tests. We did the OGTT as a standard for our tests coming in. We will see whether I have diabetes or not." Once he took that test, once he took the fasting glucose even, and he came back with such a resounding diagnosis of diabetes with hyperglycemia, that patient got religion, as we might say in the South. He said, "Dang, I did not know I was that sick." He lost 40 pounds over the next 4 months in working to deal with his diabetes. So that patient, even though he did get sick a couple of times, he got sick with COVID, he didn't take the vaccine. These patients start getting much more aware of their healthcare risks, and that is exactly what prevention, population-based healthcare is all about. Helping patients become aware of their risks, helping patients realize that you don't just ignore your health except for 3 or 4 times a year when you go get a prescription from a doctor. You take control of your health. Now, one final comment, talk about value of patients in these areas. A clear and undeniable saying in economics, value is what the market will pay for something. And the market has paid as little as $1,000 when I've seen some MSO purchase full-blown, full-risk patients from doctors for their panel at $1,000 a piece, to the frothy days of the markets where Oak Street at one point was getting like $150,000. They were valued that way. All of that has changed. Meanwhile, the private markets for risk-based models have tended to remain around 3 times revenue. Well, what's revenue? When you go back and think about it, these primary care systems that are responsible for full risk have a revenue per patient. Like I said a few minutes ago, the expected full health care costs for a Medicare patient for the year, a few years ago it was $15,000. If you take that as the standard revenue, 3 times that is about $40,000, $45,000. It will continue to vary significantly as these models settle out in the marketplace. Some continue to go higher, maybe most of them continue to go lower, but this will continue to settle out. But as a physician involved in the care and the prevention programs for your patients, think about it. I mentioned the doctor that said, "I've got 1,200 Medicare patients." And I talked with one of his patients. His patient said, "Look, I hear from this doctor, I get calls from 8 o'clock at night." He's truly doing preventive care for his patients. He's giving away those patients back to the hospital for the hospital to put them in the churn and burn fee-for-service. In the fee-for-service world, like we said, $300 to $600 per year. In the full-blown incentive models, you start getting closer to $1,000, $2,000 per year, and much, much higher full-risk models. So think about it. Like I've said before many, many times, your patients deserve preventive care. Like that patient I described a few minutes ago, with full-blown diabetes, he deserved to know that he had full-blown diabetes so he could start taking care of his health. And guess what? Just like I discussed the value of these patients in an insured preventive program, you've worked hard, decades of your life, to take care of these patients. Get them into population-based care. Get them into prevention. They deserve it, and guess who else deserves it? You deserve it too.